Good morning everyone. Today we are going to learn about metabolic and endocrine bone diseases. So first one is osteoporosis. So osteoporosis is basically a bone disease that develops when the bone mineral density and the bone mass decreases. So basically there is quantitative reduction in the bone. Then osteomalacia and rickets, reduced or impaired bone mineralization occurs due to vitamin D deficiency. Scurvy occurs due to deficiency of vitamin C, resulting in subperiosteal hemorrhages. Then hyperparathyroidism is a condition which leads to a condition known as osteitis fibrosa cystica. So it is a rare but clinically significant bone disorder, and it is characterized by profound skeletal changes, and that occurs due to excessive parathyroid hormone activity. Then pituitary dysfunction, that is both increase in pituitary function or increased pituitary activity as well as reduced pituitary activity, both will lead to pituitary dysfunction related skeletal abnormalities. So hyperpituitarism causes gigantism and acromegaly. So this gigantism and acromegaly both are due to increased growth hormone production. So as you know, growth hormone is usually produced mainly in the anterior part of the pituitary gland. So hyperpituitarism causing gigantism and acromegaly, as well as hypopituitarism, that is reduced pituitary activity, or which will lead to reduced growth hormone secretion causing dwarfism. Then thyroid dysfunction, as I told you, both hyper as well as hypo are problematic. Hyperthyroidism causes osteoporosis, hypothyroidism causes cretinism. Then renal osteodystrophy. So in some patients with a chronic renal failure, then those patients will have osteitis fibrosa cystica in the long term, as well as osteomalacia and osteosclerosis. Then skeletal fluorosis. High sodium fluoride content in drinking water can lead to replacement of calcium in bone by fluoride. Coming to osteoporosis. So in osteoporosis there is quantitative reduction in the bone tissue mass. Fragile skeleton leading to fracture, pain and deformities are seen, and it is more commonly seen in elderly, more frequent in postmenopausal women. Coming to the pathogenesis of osteoporosis. So basically this osteoporosis are mainly of two types, primary and secondary. So primary means without any underlying disease or without any underlying cause the disease occurs. That is primary. Secondary means that disease occurs due to some other secondary cause. So first is primary osteoporosis. It occurs without any underlying disease or medication. It is again of two types. One is idiopathic type and other is involutional type. Idiopathic type is seen in young people and juveniles, while involutional type is seen in postmenopausal women and elderly people. So there will be basically excessive osteoclastic resorption and slow bone formation. Coming to risk factors for primary osteoporosis. One is genetic factors. Second is females are more prone than males. Then reduced physical activity, deficiency of sex hormones, combined deficiency of calcitonin and estrogen, hyperparathyroidism and vitamin D deficiency. Coming to secondary osteoporosis. So as I told you earlier, secondary osteoporosis develops as secondary to some other underlying condition. So it develops secondary to immobilization, chronic anemia cases, acromegaly, hyperparathyroidism, thyrotoxicosis, starvation, and certain medications like heparin, anticonvulsants, etc. Coming to morphology of osteoporosis, it can be localized or systemic. So localized most commonly seen in case of immobilization. Then they cause fractures in the vertebra, femoral neck, wrist, etc. And there will be enlargement of the medullary cavity but thinning of the cortex. And active osteoporosis is there. So what do you mean by active osteoporosis? So active and inactive osteoporosis is there. So first, what is active osteoporosis? It is due to increased bone resorption and formation. So basically there is the bone resorption as well as formation is increased. So there is increased turnover. There will be increased osteoclast which helps in bone resorption, as well as there will be increased osteoid formation with the help of osteoblast. So basically in active osteoporosis there is increased turnover. Coming to inactive osteoporosis, so here there is minimal bone formation and minimal resorption. So both bone formation by osteoblast as well as bone resorption by osteoclast are reduced. So totally is equal to that there is reduced turnover of the osteogenesis as well as osteoclastic resorption. So there will be decreased osteoclast and decreased osteoid formation. Next, coming to osteitis fibrosa cystica. So over secretion of parathyroid hormone leading to increased osteoclastic resorption of the bone results in this condition. There again, as I told you, there is primary and secondary hyperparathyroidism. Hyperparathyroidism results in increased susceptibility to fracture, skeletal deformities, joint pains and dysfunctions. Hypercalcemia, hypophosphatemia and hypercalciuria. Coming to the morphology, grossly there will be focal areas of erosion of the cortical bone and there will be loss of lamina dura at the roots of the teeth. Next we will see the histopathology. So in histopathology what happens is there are mainly four main steps. First is demineralization and increased bone resorption. That will lead to replacement of the bone and marrow by fibrosis with increased number of bizarre osteoclasts. So that stage is known as osteitis fibrosa. From that it will progress to the next stage, that is osteitis fibrosa cystica stage. So there what happens? The resorption, microfractures and hemorrhages in the bone marrow cavity, these all will lead to cyst formation. So that stage is known as osteitis fibrosa cystica. Next, that will lead to next stage known as brown tumor or reparative giant cell granuloma. So what is that stage? Hemosiderin laden macrophages and multinucleate giant cells appear in the areas of hemorrhage. That is known as brown tumor or reparative giant cell granuloma. Next, coming to renal osteodystrophy. So what is renal osteodystrophy? Skeletal abnormalities appearing in cases of chronic kidney diseases and in patients who are already on treatment by dialysis. It is most commonly seen in children. There is hyperphosphatemia and hypocalcemia which will lead to hyperparathyroidism. So that will in turn lead to increased osteoclastic activity. The major lesions includes osteomalacia, secondary hyperparathyroidism, osteitis fibrosa cystica, which I have already discussed about, osteosclerosis, metastatic calcification. So these are the major lesions or major bone lesions in renal osteodystrophy. Then coming to pathogenesis, so this hyperphosphatemia, or what happens due to this hyperphosphatemia, there will be reduced renal excretion of phosphate. So that will lead to phosphate retention, leading to secondary hyperparathyroidism. Second is hypocalcemia. So there what happens is there will be decreased conversion of 25 hydroxycholecalciferol to 125 hydroxycholecalciferol. So this will cause reduced intestinal absorption of the calcium. So that is how there will be hypocalcemia. Third is parathormone secretion. So there what happens is secondary hyperparathyroidism will lead to increased osteoclastic activity. So as I have already told you, whenever there is increased osteoclast formation, or whenever there is an increased osteoclastic activity, that will lead to active bone resorption. So that this parathormone secretion due to secondary hyperparathyroidism will lead to increased osteoclastic activity, which will eventually lead to increased bone resorption. So the bones will become weak and there is very high chances of fracture. Then fourth is metabolic acidosis. So this causes bone decalcification and osteoporosis. Fifth one is calcium phosphorus product more than 70, leading to metastatic calcification. So this calcium phosphorus product is actually calculated by multiplying the serum calcium and phosphorus. Normally, the normal level of calcium phosphorus product is less than 55 square milligram per deciliter square. So if it is more than 70, then that will lead to metastatic calcification. So as you all know, pathologic calcification is of two types: dystrophic calcification and metastatic calcification. Dystrophic calcification is the calcification occurring in dead and degenerated tissues, while metastatic calcification is calcification occurring in living tissues. So that is the significance of calcium phosphorus product. Then sixth one is dialysis related metabolic bone disease. It is seen in long term dialysis employing aluminum containing dialysate, and what happens is this aluminum interferes with deposition of calcium hydroxyapatite in bone, leading to osteomalacia. So what is osteomalacia? Osteomalacia is a condition where the bones are extremely soft and weak. It is also known as soft bone disease. Coming to the morphological features. So one is mixed osteomalacia, osteitis fibrosa. That means there will be features of both osteomalacia as well as osteitis fibrosa. Then second one is pure osteitis fibrosa. That means there will be only features of osteitis fibrosa. Third is pure osteomalacia. That means there will be only features of osteomalacia. Then fourth one is renal rickets. Then fifth one is osteosclerosis. So what do you mean by osteosclerosis? So sclerosis basically by the term itself means thickened or thickening. So osteo means bone. So osteosclerosis means increased bone thickness or increased bone density. Then sixth one is metastatic calcification. That I have already told you about the calcium phosphorus product in renal patients, especially if it is more than 70, that will lead to metastatic calcification. So these are the main 6 morphological features. Thank you.